Ladies and gentlemen, please welcome to the stage Matthew Holt.
Hi everyone, we're back again. We're going to start off, but you're going to get a little bit of a treat before we start, which is I tweeted about this, but given what Brad talked about this morning, I think you'd all appreciate that this is the British newspaper, The Guardian, and this was the video they released on April the 1st. Very relevant to what we heard about this morning. For those of you who don't know, The Guardian is the left-wing, liberally, bleeding heart newspaper in the UK.
Here at The Guardian, we've always known that our future depends on meeting the changing needs of our readers. 20 years ago, you could only read The Guardian in print. Then came the internet, desktop, laptop, and mobile. But for a while now, our readers have been telling us that they want a more immersive way of experiencing The Guardian. And so today, I'm excited to reveal the latest groundbreaking innovation by The Guardian.
Another busy day, places to go, errands to run. That's where The Guardian's new augmented reality spectacles come in. To everyone else, they look like an ordinary pair of glasses. But for you, they're a direct connection to an entire Guardian universe. Wouldn't life be so much easier if you had instant access to expert reviews, cutting-edge facts, and a constant stream of specially curated liberal and left-wing opinion? Welcome to Guardian Goggles. Want a Guardian critic's assessment of the latest cinema releases? With just one look, Guardian Goggles will bring you an up-to-date review. Want to know what our team of food writers make of the place you're planning to visit for lunch? Guardian Goggles have you covered. Or perhaps you're worried that you might accidentally buy some unethically sourced food. Say hello to our onboard mini Monbio, helping you purchase with a clear conscience. And then there are those times your willpower falters. It happens to the best of us. But Guardian Goggles can help keep you on track. Our proprietary anti-bigotry technology automatically protects you from harmful opinions before they even reach your eyes. That was close.
In the past, we used to think the future would be in the future. But then came Facebook and Google+, and all of a sudden it became clear that the future is now. Guardian Goggles are the future, here in the present. So the present is now the future, which is now. It's just incredible, really.
In fact, no matter where you go, when you're wearing Guardian Goggles, you'll always be able to get the Guardian view. When you're wearing Guardian Goggles, you let us do the thinking, so you can get on with the living.
Choose from a range of exclusive designer styles, including this head-turning C.P. Scott edition, unavailable in any stores.
All right, so
I'm Michael Gove.
I thought you'd enjoy the future we're all going to be living in. So the funniest thing of the lot is the thing about Arsenal, but none of you are English soccer fans, so you missed that. But they will never win the championship again. All right. So we're going to go to the fireside chat. But first, a couple of little things. We have a Health Data Ignite post-conference event starting at 6:15, so pretty soon after this, over on Natoma Street, which is a Code for America's headquarters. And I think there are a bunch of people lined up to do some speeches already, so I'm looking forward to seeing that, and there'll be some refreshments served, I hope, as well. And then I thought, given that we had a whole lot of discussion about history of technology, I thought that it would be good for us to read this. Because I think so I'm going to read this to you in my plummy British accent. In attempting to arrive at the truth, I have applied everywhere for information, but in scarcely an instance have I been able to obtain hospital records fit for any purpose of comparison. If they could be obtained, they would show subscribers how their money was being spent, what amount of money was really being done with it, or whether the money was not doing mischief rather than good. So do you think this was said by George Halverson, the CEO of Kaiser, when he decided to buy Epic? No? Guess who said this? Louder, come on. Don't be shy. Ben, kind of like, but not a bad idea. Same nationality. Somebody whose name has already been mentioned quite a lot today. Florence Nightingale, that's right. Florence Nightingale wrote this about the same time as she made those other charts. This is basically about her problems getting health information data in one place for comparison purposes. And this rings pretty true today, right, for most of us. So with that, I'm going to move on to introduce my panelists. And we have coming out, Emily, Caroline? Great. Right. So this is Caroline Danielson. She's a research fellow at the Public Policy Institute of California. And on her right, sitting cleverly underneath their names, not across from their names, as we had it earlier. The little things matter, right? This is Emily Putnam-Hornstein, who's an assistant professor at USC. But don't worry, she did her social work degree at Berkeley. And she only flies down to Southern California occasionally, I understand. So
that's right.
So it's all OK. All right. So I'm actually going to let them talk a little bit about what they're doing, but the whole point of this session is to really think about a couple of things. One is from a researcher's point of view, how do you deal with the issues of data, and when those data are in different places, in different systems, different silos, but it's much more powerful if you can pull data sets together. You saw Derek Van Brunt and Healthy Communities Institute and many others showing data from multiple different sources on one screen. And that's all great and all well and good, but we're still not yet in a world where, we're still in a world where Florence Nightingale will recognize the data isn't all together. So I'm roughly, and I'm only going to say this very quickly, we're going to start with Caroline. We're talking here about their research topics are somewhat different, but you'll find many of the principles we're going to talk about very familiar. And I want this to become very interactive. So what we're going to do is have them each go about 5 minutes on what they're doing, and then I'm going to ask a couple of questions, and we can go straight to audience Q&A, because frankly, the questions I've heard from the audience here have been much, much better than anything that me or other moderators could come up. So with that, Caroline is going to talk mostly about coverage, and Emily's going to talk about kids. So Caroline.
Thank you. This is a project. The project I'll be talking about is something that's really still in its planning phases. So having listened to a really interesting morning and early afternoon of presentations about sort of fully cooked or nearly fully cooked data visualizations and data that are out there, this is really taking several steps back and thinking about ways of getting data together to get them to the point where you can do such cool things, as we heard earlier. And so let me talk a little bit about the issue, the problem that gave rise to our need for these data, or our proposal to use these data, and then talk about the data themselves. And let me say at the outset that this is research supported by the California Healthcare Foundation and the Blue Shield Foundation of California. So the Affordable Care Act. We all know that right now our health insurance coverage in this country is based on either mainly employer-provided insurance or means-tested insurance. So you're poor and you qualify for Medicaid. There's also programs for the elderly, but the working age population and children get insurance from those two sources. The ACA aims to fill in the gaps in between those two systems to patch it up so that everyone has insurance. So universal coverage and ideally continuous coverage for the purpose of promoting health. So think preventive care, think broad-based risk pools. So really the ACA is trying to patch the system together to provide universal coverage. That's the policy problem that with our research we're hoping to address by bringing together some data sources, because we know that generally speaking in means-tested programs like Medicaid, but also as mentioned earlier this morning, food stamps or CalFresh, also known as SNAP federally, true of welfare programs, true just generally of means-tested programs, take-up is not universal. Take-up is 50%, roughly speaking, in CalFresh. It's even lower in CalWorks, which is California's welfare program. We know that currently there are about 2.5 million eligible Medicaid, eligible but not participating Medicaid people eligible for Medicaid but not participating right now in California. So to envision a system where people are more continuously, more universally enrolled requires thinking about a number of different issues, behavior and whatnot. Our aim, our attack is to think about the problem of pegging eligibility to certain levels of income. So you are eligible for Medicaid if you fall below a certain level of income. That's going to be expanded so that people at somewhat higher levels of income will be eligible for the program. But still, if your income changes during the year, or in principle during from month to month, you can switch eligibility, and that can create a gap in coverage. So what we need to know more about, and that we don't actually have good enough answers to, is how do people's incomes change from year to year and within a year? And what can we do to mitigate those events, especially for populations, for people who may be near the poverty line? Their incomes are less predictable, more volatile, and this is a particular problem and can lead to underinsurance. So that's the issue that we're hoping to address with our new sources of data. The data are bringing together in a couple of different ways, two or three sources of data. And the couple of ways are, in the first place, to marry survey data, so information about the population, to government-collected data, and here Medicaid enrollment records and earnings records that employers provide to states as part of their unemployment insurance programs. So marrying survey and administrative data, and doing this at different levels of government, because the survey data collected by the Bureau of the Census are federal data, and the Medicaid and earnings data are state data. So bringing those two levels of government together, bringing the two types of sources of data together, and bringing together the strengths of both. So the fact that the census data, and this is the American Community Survey, which is a 1% sample of the population. Does that qualify as big data? I'm not sure, but it's certainly big data in census terms. It's about nearly 400,000 records, individuals in California each year. Marrying the survey data, that's a sample of the population, with the longitudinal, so the overtime information that you get about individuals, about their earnings, about their enrollment in Medicaid, and at least historically speaking, healthy families, California's SCHIP program, to leverage the strengths of both and really bring together the synergy so we can learn about the people who are not enrolled in programs as well as people who are enrolled in programs, and learn more about their characteristics, learn more about their variability over time, and help to bridge the gaps in insurance coverage to make the ACA more successful in California.
That's great. So let me just ask you specifically about a couple of points around the sort of mechanics of this. I know you haven't, you're in the process and you haven't done this yet, but and you can give us some ideas about what you might come out with as conclusions. But just in the mechanics, how do you think you're actually going to put these data sets together? I mean, you have these large data sets. How do you get access to literally to the data files? Do you have teams of researchers working with you with SAS spreadsheets? What do you actually have to do to get this done? We're going to come back to. We'll revisit this at the end, by the way. But
sure. So some of the examples we've heard about earlier are aggregated data, just bringing together different data sources and mashing them up. We're talking about one-to-one linkages for the same person between a survey data source and an administrative data source to learn about that person, to get a fuller picture of that person over time. And to do that, we are really relying on a census infrastructure. They've set up something called the research data centers in universities around the country now. There's roughly 24 of these, including 3 in California. And these are secure data centers to maintain confidentiality, where you can get access to the data that have identified information so that you can actually do the linkages. Now, it's not strictly speaking identified information. You don't know the name and the social security number of the person's records. You know what's called a protected identification key, which is an encrypted identifier that's unique to that person, but not something identifiable that you would yourself recognize or that someone on the street would recognize. So there are protocols and processes for accessing data at census data research centers, and we can talk more about the hurdles of doing it there. And so that's an advantage of this research, is that we're building on an existing infrastructure that the Bureau of the Census, the federal agency, has put in place in order to make data more available to research.
Right, but we're also talking about linking data around healthcare, and we haven't heard the words IRS, but it's been in the news lately, and there's a whole series of issues which you can imagine around privacy and Harty, which will come
For sure.
up. All right, excellent. So Emily, let's switch gears to you, and now talk. As I mentioned briefly, you have a PhD in social work, and but a sort of training as epidemiologist. But you also were a case manager for kids in New York before you came back to graduate school. And your research is kind of around that same topic. So why don't you tell us a little bit about that?
Yeah, so I'll start by saying that usually I have PowerPoint slides, and so I was a little bit nervous coming out here without the slides. But
You're
given
better
that
without them, don't
given that we're following the visualization group, I realized I would have been totally shamed by my graphics. So this is probably better. But just to give you my 5-minute agenda, I'm going to start with a historical tidbit, since Andy and everyone else seems to have been enriching the day with those. I'm then going to talk a little bit about the project I'm working on, and then I'm going to give you 2 or 3 kind of case study examples of some of the knowledge that's been generated. So first, my historical piece, going back to I think it's 1946, the first reference to record linkages was actually published in the American Journal of Public Health, and it was described as every person in the world creates a book of life. It starts with birth and ends with death, and record linkages is the process of assembling the pages of that book. And I would say that kind of in a nutshell, that's what I've been trying to do. So on to the project. As Matt mentioned, I got my PhD at Berkeley, and UC Berkeley and the School of Social Welfare has a very long-standing collaborative relationship with the California Department of Social Services. So that for more than a decade now, we've actually received extracts of all of the administrative child protection data from the state of California. And what we've done with those data is we've been able to demonstrate that we can house them securely, and so we've got all the confidential information. And we've used those data to support the state in tracking child welfare outcomes, performance measurements that are mandated by both the state and the federal government, and those are actually publicly available on a website. But what we discovered is that while there was a whole lot we could ask and answer using that child protection data in isolation, there were also any number of questions that we were very interested in that could not be attended to with just that single source of data. So you have to remember that, administrative data that's used by public agencies was really kind of developed. Those systems were developed for case management purposes, not for informing policy, not often for tracking outcomes that kind of go beyond one particular system, and not for research purposes. And so what we were finding is that we had information concerning children who had been reported for abuse or neglect, but we had no information regarding what those children looked like before they were involved with the system, or what their outcomes were after they left the system. So we're kind of delivering all these services. Do we find that some children are doing better than others after they leave the system? We really don't have that information. And we also didn't have information that allowed us to kind of help frame these children and maltreatment within a broader public health narrative in terms of how these children fit within the overall population of children in California. So what we've been doing over the last few years is we've been able to take that child protection data that we have, and we've got tens of millions of records, mothers, fathers, children, siblings, and we've been able to acquire a few other population-based data sources from California. And we've then been able to link individual children and families across systems. So one data source that we've been working with has been vital birth records from the state of California. So we've been able to obtain from the California Department of Public Health birth records for all children who were born in California from 1999 through 2010. There are roughly 500 to 560,000 children who are born each year. And we've been able to take the information from those birth records and link it to the child protection records so that we can identify in an overall birth cohort which children are reported for abuse or neglect before the age of 5. And we've been able to do those linkages using the confidential information that, as researchers, we've been able to access from those 2 different agencies. We've been able to use open source software, so we actually used a probabilistic linkage program that was developed by the CDC. And what that's allowed us to do is to, one, obtain a whole lot more information about children who are maltreated than we previously had. Because now all of a sudden we have all the information, all the variables that are available in the birth record data, but were not collected in the child protection data systems. We've been able to document, for example, the cumulative prevalence of children who over time have contact with the child protection system, which is much greater than we'd kind of previously been able to estimate using single-year counts. So, for example, we know that in the state of California, in any given year, around 5% of children in the state are reported for abuse or neglect, and less than 1% of children actually end up in an out-of-home foster care placement. So, relative to a lot of other kind of public health and social problems, often the problem of child abuse and neglect gets kind of pushed to the back burner a bit. But when we actually look at over time from birth through just, the entry into kindergarten, how many children at some point touch the child protection system and are at some point identified by someone as a possible victim of abuse or neglect, we find that the number of children is 3 times higher. So it's actually 15% of children in California are reported for abuse or neglect by the age of 5. We know that almost 3% of children at some point spend time in foster care. So that's just an example of some of the information that we've been able to kind of glean from that. And we've also been linking up with death records. We've linked up with emergency department and hospitalization records, substance abuse treatment records, so we can figure out which parents are receiving treatment and how does that impact outcomes in the child welfare system, educational data. So most of these have been kind of one-off linkages, but that's kind of the project.
So that's fascinating data, because you're now talking about understanding insights about populations you wouldn't have seen from a snapshot or from one data record by looking at that. So I mean that's a great example. So Caroline, without putting you on the spot because you haven't done the research as yet, but as you're bringing this together, what do you think are likely to be some of the sort of potential snapshots that you might potential findings you might find out about by doing these data linkages that you can't get from current data sources? Look, the researcher in her brain is boiling.
I don't think we can find out any of this with current data sources.
Right.
No, so we can. There has been research.
Well, let me ask you. I could tell you right now that people of lower income, who don't work as much, who are likely to be ethnic minorities, are less likely to have health insurance currently.
Exactly.
Big whoop. To get from there to something more useful, you're doing this.
Right. So let me start by saying that the census does collect longitudinal data, but it's self-reported data about people's earnings and their participation in programs and whatnot. We know that there's a large and honestly, in many cases, growing problem of misreporting or underreporting. So people are either forgetting or deliberately not telling people when they're surveyed, the interviewer, accurate information. And it's a combination of a number of things. It's well documented by a lot of research, so that survey data sources are expensive and they're just providing less relevant information than maybe they did in the past. But we need to know that kind of information still. And so marrying some forms of survey information that's a little better reported, like your self-reported family relationships, which is a really useful concept because we want to know who's filing together as a tax unit, for example, or who's applying for health insurance together as a health insurance unit. Marrying that with more accurate administrative data that's also longitudinal gives us a picture of people through time, as Emily was saying, can be really powerful. And what we'll learn, or what we expect to learn, is times, places, populations that have particular problems, or the reverse, particular advantages with the sorts of income fluctuations that would lead to lack of coverage, health insurance coverage in our example. So for example, you could imagine times of the year, or where the economy is especially cyclical in agricultural areas, or during a recession, or types of families, so family breakups or the birth of a new child, where you can identify and then and predict, have a predicted probability of income change that would put you over or under eligibility thresholds for a particular kind of program. So then you could do targeted kind of outreach. If you wanted to do it in a more broad-based way, you could, alert caseworkers. You could alert community organizations. You could alert individuals if a means were made possible. If for certain kinds of groups, certain regions, times of the year, years, right, where these are particularly an issue.
So, I mean, it reminds me somewhat of some of the data we saw, some of the programs we saw earlier from the folks at Healthy Communities Institute and St. Francis, where they said, okay, we have these particular individuals who basically have problems with alcohol or whatever, and come to the emergency room, and instead we're going to we'll do a specific policy problem that fixes this once we've identified them at the individual level. I mean, are we talking in these cases about going from generalized research to actual individual, small group solutions? Is that for both of you where you think this kind of research ends up? Or do you think it stays more on the sort of research, ivory tower, more general policy formulations?
Well, I'm happy to take that one. I mean, I think that right now it probably starts with the policy, but a lot of what we've been able to do with, again, just the birth and the child welfare and the death records has been to really highlight groups that have particular vulnerabilities. And so I think that could really inform targeted prevention services. What we've been able to show is that we can actually develop predictive risk models based on the birth record data that could almost be, for example, automated on the day a child is born, that will tell us the likelihood that child is going to have contact with the CPS system before the age of 5. And if we have that information, we could then take it to the next step and risk stratify that population of births, ensuring that the highest risk children are prioritized for what end up being a limited pool of early intervention and prevention services, or somehow targeted differently. And I think there are some really kind of creative ways that you could cost effectively evaluate that by tracking children who had a similar risk profile but may have not received an intervention. So I think there are a lot of opportunities to move down to that person level. Yeah,
and it seems to me that's where we're going a lot in the whole process of health data. And the other thing we're doing in health data in general is bring in other sources of, the boundary between what's health care and general health and general societal data. That's obviously breaking down as well. So I'd encourage you in the audience to, if you have a question or want to start thinking about formulating it, because after the next question, I'm going to invite you folks in the audience, and most of you know a lot more about data and data integration than I do. But for a start, let's talk about some of the barriers. Why is, obviously, confidentiality when you talk about individual data record linkages is one big issue, but what are some of the other issues that come up and are sort of preventing more of this kind of holy grail of knowing about the whole group and then getting down to the individual? So
what's really nice about our project is that the Census Bureau has recognized a need for bringing in outside researchers and has put together a structure for making that possible, and these are the Census Data Research Centers. And the structure also includes creating these protected identification keys, or PICs, so that individual information is protected and it's not released publicly for anyone to use. At the same time, I think this is still a movement in its fairly emergent phase, so that there isn't the support to make this broadly accessible to a wide researcher community.
So what will that take? I mean, to get it. So I think you're saying that you're special, which you are.
No, I would say that the process of getting a proposal approved and the number of hurdles to get a proposal approved takes a number of months. So the idea that you would produce research that would be ready to be consumed in a timely fashion is a bit of a difficult prospect. But there's a separate issue, which is that Census has their own data. They collect survey data, but then they have agreements with other entities at other agencies and at other levels of government to share data. But in order to provide those data to external researchers, they then need to either extend those agreements or ask for permission from those other entities. And so government permissions and the idea that we have a decentralized system of government is really a hurdle in accessing these data, because the ownership of the data rests with these agencies and entities at different levels of government. And you need to negotiate that as well.
Is that any different for you?
I guess I would just look at it at a slightly different level, which is that I think that it's also important, and this always comes up when we kind of present the findings from some of these linked data. I actually think that researchers have it pretty easy. I mean, yes, we have to jump through some hoops, but I think where the real hurdles lie involve kind of the real-time access to data. Because I can tell you when I go out and I present these findings to public health agencies and child protection agencies, they're so intrigued. But ultimately, what they want is they want their frontline workers who are delivering services to have access to information concerning clients that currently can be found in other data systems. So child welfare workers would really like to have educational data and health data. And I think that that's where there are a lot of challenges in terms of how do we negotiate those data sharing agreements between agencies. As a researcher, I get to kind of be the third party, where yes, I have to go through the various IRB protocols and demonstrate, you know, there's going to be something useful at the end of the tunnel in terms of how I'm using the data. But ultimately, I'm aggregating up and presenting kind of statistics, and so there are fewer confidentiality issues.
So any comments or questions from the audience? I hope we haven't stung a couple of microphones. Please just come up, grab one. While you're walking to the front, I'll ask you guys a quick one. Any thoughts about if putting this together wasn't a problem? If getting all the data from that you know is collected already, getting it together, single, you know, getting the key in, you don't have to worry about these types of things. What would you be able to do that you can't do now? What is it that's just too hard to get to, but that you could do beyond that?
Okay, I'll jump in. Randomized control trials, it's the gold standard of research in medicine. It's very, very difficult to do in the real world when you're delivering various interventions. I think that if we had integrated data, there would be all of these tremendous opportunities for doing very kind of cost-effective basically RCTs, where you're not having to go out and collect information, but you're using extant data to track outcomes.
You're not proposing leaving some kids in houses where they are being abused and then taking others out and
No. But in terms of when we take them out, the interventions we deliver, we have opportunities there.
All right, we have a couple of points from the audience. Did you have a quick reply to that one, Caroline, or are you?
I think there's a really interesting prospect of creating population-based data out of administrative data sets. So instead of relying on, as I am in fact planning to do, a survey, a population-based survey, and then bringing in administrative data sources to overlay various administrative data sources and link them so that you're talking about individuals in a way that protects confidentiality, but at the same time builds up a picture across the different kinds of information that different levels of government and agencies within governments collect.
No, great idea. Okay, we have a couple of questions, and given we've had, I've noticed from, I'll be gratuitously sexist here and say that we've had a lot of women asking questions from the floor, so we have finally have a man asking a question. So
wow,
please.
My goodness. I don't want to represent all men up here. That good. You might have touched on it. This question, I think, is more for Emily. You might have touched on this in terms of access to real-time data. I'm a reporter. I write about healthcare issues, and but I'm also a person who grew up in an area that was highlighted in one of the presentations here. I grew up in San Bernardino, California, which is a place that had a lot of very high, has a very high homicide rate. It has high rates of infant mortality. It just has a lot of very tough things to grow up with there. So your research is incredibly fascinating to me in that it would want to predict the factors that might lead to a kid being put in the system and institutionalized. But one thing that happened in San Bernardino, and this would go back to the 80s or 90s, was that things happened in that community that you couldn't necessarily predict. Kind of in a row, there was a train terminal. The Santa Fe Railroad train was a big employer there in town, and that shut down. And then shortly after that, there was an Air Force base that called Norton Air Force Base, which shut down. And then there was a steel mill, the Kaiser steel mill, which shut down. So basically, the working class in that community had no more access to jobs. And those jobs, you know, as the adage goes, never came back. So is there a way to adjust or try to somehow account for the unpredictable in your work, maybe account for the economic factors, globalization, things like that, that would give you kind of some insight into what might happen in the future you know, for these kids?
Well, I think it's a terrific question and a terrific point. It's something right now, all we're doing is we're kind of clustering for within county because child welfare systems are delivered at the county level. But I think it speaks to, again, the potential of harvesting data from all sorts of other sources to improve our understanding and our predictive models or our kind of how we target services and resources. And so while right now what we're doing is we're really looking at kind of individual level risk factors, certainly I think that, you know, kind of what Caroline's doing with the census data, I mean, there, again, I think that you could continue to layer on other data sources that wouldn't necessarily get to all of the kind of the random noise, but would improve things.
Yeah. No, I mean, you're talking about putting together, there was that chart that Brad showed this morning, which had, we already got to a smidgen of how much data for the big data is going to come. There's even more going to come. You can imagine some of those factors coming into it.
Let me just put in a pitch for analytics here, because I think we've talked a lot about data, and it's critical and really important. But some of what we've talked about also is the analytics making these data useful and interpretable. And some of the fancy stuff that researchers do is actually useful in that regard, because bringing to bear, you know, what happened when a plant closed in some other place, and adjusting for the other circumstances that were different from San Bernardino County could bring you to at least a partial answer to that question without having to wait until after it had happened there and then learning retrospectively, but trying to still learn and be able to apply it in a more predictive kind of sense.
But you can imagine if you could make the connection between the macro and the micro, and you know, that might lead to a whole bunch of social policies you think about if we were going to close down a plant or close down a road or whatever. And there's some big impacts from that, which, you know, you can say that's going to directly hurt children, or that's going to increase the rate of uninsured or whatever. So, your question, ma'am.
Vicki Mays, UCLA, and I'm also a member of the National Committee on Vital and Health Statistics, which is the Federal Health Advisory Committee. So these issues of data linkages, we've worried a lot about, talked a lot about, so I have a question. One of the things about the census data is that the census has been very good about having these sites, particularly within academia, and they even have some community sites to get data out. But what you really want is to be able to link the census data with some of the NCHS, the National Center for Health Statistics, like the National Health Interview Survey, et cetera. But the census is controlled by Congress, and there apparently are these firewalls where that data and other data sources cannot reside in the same place. So do you have you thought about this at all? You know, if you have the answer, this is like, you know, the million-dollar question of, is there some way to be able to link the NCHS data sets with the census in any way that you can think of?
So I can't particularly speak to the NCHS data, but we have somewhat of a parallel, but maybe not as difficult situation with the Medicaid statistical information systems data. So states send individual level Medicaid and SCHIP records to the federal government, and they've been doing this for more than a decade as a requirement of federal funding for their programs. And CMS does have an agreement with Census to share those data. It turns out in our case, they need to amend that agreement in order to make it available to Census RDC researchers. But it's a doable thing. It's a proposition that is at least feasible. And I think that the Census RDCs, a lot of the research there is actually not used linked data. It's just used confidential aspects of those data, and the linking is still in its initial phases. And so some of these agreements and the thinking about making data linkages possible is still really in its beginning phases. And I think there's probably some momentum coming and being created, hopefully by our projects like ours and others that are really trying to do this, and so that they'll be responsive.
Well, write about it so that the committee can know about it and we can try and increase it.
We will. Thank you. We will.
I mean, one would hope that the concept of data liberation that Todd Park and others have been espousing all these years now actually covers many other parts of the health universe of data, because as I said, the one thing we understand is these things are all interconnected. I think we've killed the answer to questions, so now I get to ask you what you want to ask them, which is, so we don't have that many. We have a decent number of tech folks in the audience, and we have a decent number of data people in the audience. What would you like the audience to do to make your lives easier so you could get to the interesting research post this? What kind of tools, services, data sources, mashups would you like to see that meant that you didn't have to do all that grungy work of the data cleaning and data linkage yourself, but could come from, but you could then do the policy stuff and do the next part? What would you like to see? What would you like to see done for you that you have to do yourself right now?
Well, I would actually start with common agreement about confidentiality and what's okay to share and what's not. And I know those are difficult questions, but I think there's different answers depending on the part of government you talk to or the level of government you talk to. And there's too many different answers, and it creates uncertainty and a lot of hurdles in terms of lawyers and agreements. And so
this is intergovernment standardization agreements on what can be shared and what can't be shared, but sort of
and I think
highest rather than lowest common denominator, I think is what you're talking about.
Yes, and so a high bar, but a common bar, so that it's clear what you need to do to meet it, and instead of multiple standards.
Emily, what's your wish list?
That's a tough one.
Someone builds a better Excel? I don't know.
No, I mean, I guess I was thinking, I was at a technology conference the other day where they had a case study, and someone was presenting information from the hospitality kind of field, and they were talking about the fact that they have people making reservations from kind of the web, the phone, the front desk, and they were trying to figure out a way to kind of integrate all this information. And there were all these kind of smart tech people in the room, and the private sector was clearly kind of involved in this. And what I found is that it's very hard to, government was designed to be very deliberative, and so public agencies are often struggling to kind of move forward with technology innovations, and so finding ways to kind of better kind of match those who have the skills in the private sector and the lessons learned in kind of very analogous situations around kind of reconciling data from different systems, helping the kind of the public sector to kind of learn from those experiences. I think would be great.
So you want the Harris Casino solution, when they know when you walk in the door, how much money you're going to gamble, where you stayed that night, how much you're drinking, and to use that kind of tools to bring it all together.
That would be great.
Great stuff. Well, that's fantastic. Well, I think you're both doing really interesting, fairly pioneering work. There's obviously a big gap between worrying about populations, worrying about individuals, and actual services we can deliver. But I want to again thank you both for coming to Healthier Communities Data Summit and sharing your time with us. So can you all please thank Caroline and Emily?
Thank you. Thank you.